Thanks for taking the time. So I'm going to just roll through some cases that I think point out some different things where LITT has some utility. I started 4 or 5 years ago, start using LITT, and the first challenge was just trying to figure out when and where. It became very easy on the epilepsy side to figure that out for me. But on the tumor side, it was very much this light switch had to come on of, I'm looking at a patient and I'm looking at a film, and my first question is, is it resectable or not? And if it's not resectable, am I going to biopsy it or not? Getting to that point where my brain clicked that, okay, is it resectable? Is it laser ablatable, if that's a word, or does it need to be biopsied? Just getting that to be an equal part of the conversation in my brain is really what I'm hoping that I can sort of show some things today. And I've had the advantage that I work in a multidisciplinary group where the radiation oncologist and the neuro-oncologist very quickly became enamored with the idea of some of the minimally invasive opportunities with the procedure. So they'll often come to me and say, hey, do you think this is something that you could use the laser on versus a traditional craniotomy? So I'll just sort of go through this. If I'm going too fast, slow me down. If I'm going too slow, speed me up. And I can talk about workflow a little bit if you want. Just to start, I do not have an intraoperative MRI, so I have a diagnostic MRI scanner. So I do all of my cases where I implant the anchor in the operating room, and then we transport downstairs to the MRI scanner and do the procedure in the MRI and the diagnostic MRI scanner. Just let you know that now. And if people have questions about my workflow in particular, I can stop at any point and talk about that. So let's get started here. Let's see, can I get it to work? Oh, disclosures. Okay, so I'm just going to run through these. This is a patient that I saw. He's 18 years old when I got my hands on him. He was a pediatric patient to begin with. He was found to have this small area of enhancement in his basal ganglia when he was, I want to say 14. That might be right. He might have been younger, 12. It was routinely found. He was asymptomatic, and they just followed it with surveillance MRI scans. Eventually, he graduated out of the pediatric group, and I took over. And of course, magically, when I started to see him, the stupid thing started to grow. And so this is a coronal from 2012, and then a coronal from 2017. He's still asymptomatic at this time, but we don't like the fact that it's changing. So in 2017, we performed a stereotactic biopsy, and it came back as a JPA. Obviously, that's not something that we're going to, well, I won't say obvious to anything, but this is not something that I was inclined to consider for an open craniotomy. Typically, in our practice, what we would do with this patient is we would say, well, we know what it is. It's growing. We probably should, offer radiation. But with the laser, we were able to sort of think about some other things. So let me go back a second. So this is an inaccessible lesion to me. And so, a corridor via a 3.3 millimeter probe is very attractive versus any other option that I have, whether it's one of the port systems or anything like that. So what we did was we targeted the lesion. I used the SideFire laser for this. The nice thing about it is it has a directional component. The negative of it is it's slower, so it's a little bit slower to heat. And I'm going to try to play this movie for you. Well, let me just walk through this picture because this is sort of the standard picture you're looking at on the software. The bottom two images sort of demonstrate where the laser is located. So that's the trajectory of the laser, and that blue is really showing where the laser is, and it's a little difficult to see, but there's a little dot there. That's where the laser fires from. And you can see these three perpendicular lines. They correspond to the pictures up here above. In this middle picture, you can see this little blue arrow for the SideFire device, which has this directionality. That's the direction that the laser is pointing, and you can rotate that. And one of the nice things about the device is you can withdraw, you can move the laser deeper or more shallow, and you can rotate it while you're sitting at the computer. You don't have to go into the MRI suite to adjust it. You can do it through the robotic driver. So let me try to play this for you. And we won't play the whole thing, but what we will hopefully see, is it playing? There you go. So you can see around 6, 7 o'clock that yellow is starting to come up there. And then you see the blue. The blue line is the temperature that we're targeting. That's what we want to get. And it's a little difficult to see on my screen. I hope you can see that as I move the arrow, we start to change the direction of the heat. Then we move up. So I just pulled back a little bit. We're starting around 4 or 5 o'clock. And you can see where the heat is moving in that center. And as I sort of rotate, as I spin the blue arrow, you can see the directional heating. This is a really nice example. This is the best example I had back then of directional heating. I won't belabor the point, but you can sort of see how that's going around there. Let's see if I can move on to the next slide. So post-op, he actually had a little bit of weakness that got better over the course of a couple of months. Very, very subtle, but it was there. And here you can see a number of images. This is the original. This is 1 day after the procedure. 6 months on the bottom left, and then 2 years post-op. This is what it looks like now. It hasn't changed. You know, why is this a nice lit case to me? Again, deep, inaccessible lesion. I'm not going to operate on this otherwise. It allowed us to keep him from being radiated. We keep that in our back pocket if this thing ever does grow. I'm optimistic now over 2. I mean, it was showing not rapid, but it was showing a significant growth rate from sort of 2016 to when we started this process, and we've seen nothing so far. So I'm optimistic about that. Any questions about that case, or I'll just move on to another one? But this is an example of without lit. It took me a while to say, is this something that I could use it for? So, any question? Yeah.
Yeah. So what if it starts growing again? Would you radiate it, or would you treat it again with lit?
So I think I'd biopsy it. Oh no, that's not true. I don't know. You know, it's a good question. I'd probably radiate it. I would probably radiate it, but I think you could consider it. But I think honestly, what I would probably do is I'd probably radiate it at that point. You know, for some reason I was thinking as if I'd radiate it, I need to biopsy it again to make sure it was the same thing. But I would probably not lit it again, but I think it would be reasonable to consider. It's a good question. All right, let's move to another one. So this is a 76-year-old right-handed male. He came in with some gait instability. These are his images. So he's got this right posterior mesial temporal enhancing lesion, minimal edema. When I looked at this, you know, we were thinking, is it a MET? Is it a glioma? Meningioma was actually on my list, and I don't know how many folks would have meningioma on their list, but I had just gotten burned by a case just like this that was a meningioma. So, you know, unfortunately, when we act based on our last outcome, you know, all of a sudden meningioma was on my list. I think it's relevant to talk about because at this time in my career, I have not used the laser on any meningiomas. And I really don't think that I ever will. Maybe some data will come out eventually that convinces me otherwise. I have concerns about the firmness of a meningioma, and so I've avoided that. But this patient was interested in, you know, we needed a tissue diagnosis and we needed a plan. So what we decided to do was we decided to start with a stereotactic biopsy. And we told the patient, if this comes back as a meningioma, we'll just convert to a cranie and take it out. But if it comes back as a MET or if it comes back as a glioma, we'll use the laser. And so we targeted basically the center of the lesion. We did our biopsy. It came back with a frozen that was consistent with glioma. And again, I used the side fire probe for this case. The reason I used it here was I was trying to accomplish this, get this lesion covered in one trajectory. And with the side fire, with a sort of egg-shaped lesion, I wanted to target right in the middle and try to push heat out in both directions without creating a big sphere of extra heat above that I would have done with a diffuse tip. So the side fire's got that great ability to have that directional heating. One of the pitfalls with side fire that I have found is this, we call it this MR thermometry data artifact. And I cannot do a good job of explaining to you what it is because I don't really understand it. But what we sometimes see is this artifactual low temperatures, cooling, and it kind of screws with your mind a little bit while you're working. This case actually shows it nicely. I'm going to start this video up. So again, let me see if I can pause it here. Am I paused? Okay. So again, on the bottom two screens, you can see where the probe is going. I'm actually pleased with where it's positioned. It's right in the center on the AP, so if I can get the laser to push farther out directionally forward and back, I'm going to get nice coverage. It's a little bit, the tent is there, so I've got it a little bit lower so I can push forward, thinking that the tent is going to block heating, is going to act as a heat block from getting into the cerebellum. And where I paused it, you can see that directional heating starting to occur. I'm going to try to start it up again. Touch this. Oh, darn it. I knew I was going to do that. Let me try again. So it starts to heat. We're getting that directionality. We're angling up. You notice we're starting to see this blue through here, and in the right there, you can really, this pink and purple and blue, that reflects cold. So that shouldn't be what we're seeing, but that's something that we see with SideFire. In these circumstances, I sort of just keep going, and then what I do is I go ahead and get my MRI scan, and I see what I see. So that's the only thing that I've really found to do in this situation with this MR thermometry artifact, is basically heat and then stop and get a scan where I give some gadolinium and see if we're actually seeing what we expect to see, because I don't really think that that is getting cold. It shows that it's getting cold, but I don't think that it's getting cold. So this ended up being a GBM. It was MGMT positive. He got, given his age, he ended up having abbreviated radiation. So he only had 15 fractions, but he had Timidar, and he went on Optune up front. And these are what his images look like. The left column is the next day. So you can sort of see this enhancing halo. This is what I look for, this enhancing halo around the lesion that I'm targeting. Here it is here. You can see there's some edema that we've induced. And this is what it looks like a year later. So he's done remarkably well for an upfront GBM. Why do I like LITT for this case? Again, I like minimally invasive surgery, so I'm biased that way. If I can do a surgery where I'm going to have less pain and faster recovery, I like that. Okay, so I'm biased that I like ideas of minimally invasive surgery. I like, it's a deep lesion. It's a less traumatic corridor to get to it. You can certainly do this open, and I almost did. So this is what this case looked like. Any questions about this case?
I've had a few issues with that where it looks like it's getting cold too.
Yeah.
When I see that actually, because it sometimes comes up rather rapidly, and that's actually kind of a, for me, when I see that, it gets me worried that we're dealing with phase wrap. It's actually really hot, and so it could be a sign of either maybe gas formation or possibly bleeding. So when I've run into that, not that I've done a huge number of cases, but when I see that, I usually that's my impetus to stop ablating, at least, and sort of at least check to see what's going on.
Yeah. So what I do is I stop and I let things cool off. If I'm at a higher temperature setting or power setting, I go down on my power setting when I come back up. So one of the things that we see with SideFires was you increase the power setting, you're more inclined to get that artifact. And the last thing that I'll do is, if I'm really not sure, if I'm really concerned, I'll just get a scan and see what we see. And I do think, I don't think it's cold. It may be that it's excessively hot, but I don't think that it's actually cold, because every single time I've seen it, I've ended up getting the lesion that I want to get. I've just had to go through the stress of not being sure. Okay.
How do you control where the heat is dispersed?
So the first way you control where the heat disperses is where you place your probe. I mean, this whole operation is fundamentally set on where you get the probe positioned. I mean, and that's not just where you target, but that's where it ends up in the operating room. So I would say that's first. After that, there are some sort of natural heat sinks. A ventricle is a heat sink, a cistern is a heat sink, blood vessels are heat sinks. The tentorium, like I mentioned in this case, it's a heat sink. So I think you can be strategic to some extent about where you place the probe, knowing that you've got those heat sinks around you. So sometimes if I want to make a bigger lesion in a certain direction and I'm up against the ventricle, I might actually target a little bit, away from the ventricle, knowing that if I'm getting bigger the way I want to, I know that I'm going to get stopped by the ventricle over here. Honestly, it's sort of it's a little bit of an adventure every single time, because you really there's just so much heterogeneity that you really just you never know for certain. But I always sort of think about what I believe an ideal lesion based on that probe will look like, and that's how I plan it. So when I'm planning it, I'll plan for, okay, I'm thinking I'm going to get a 12 millimeter burn, so or I'm going to get an 18 millimeter burn, or whatever the case may be, and how many trajectories am I going to need? If I'm using more than one trajectory, how am I going to place them such that they're not duplicating each other's work? Things like that. I don't know if that answers the question, but all that comes into play as you sort of go through the process.
David, why did you choose to come lateral as opposed to kind of a mesial temporal epilepsy type approach?
That's a good question. Honestly, it's because I wasn't sure if it was going to be a laser case.
And if you were going to turn it.
Right, there was a chance I was going to turn a cranie, and that's the reason. But I think an epilepsy approach, if you knew you were going to laser this from the get-go, again, I had this weird case where all of a sudden meningioma was on my differential. When I built this thing, I was like, nobody's going to think that could have been a meningioma, but I did at the time. So that was the rationale. So these next few cases for me are kind of, these are bread and butter cases for me. And the next few, I'm going to sort of highlight some different things. Cutting to the end, they're all lesions that are METS that were radiated with stereotactic radiosurgery, and now they're recurring. And the question is, are they recurrent METS or are they radiation necrosis? So this first one is a 76-year-old with small cell lung cancer. Given her age, she did not get prophylactic radiation. She developed 7 METS that were treated with SRS. They were asymptomatic. They responded well. She then developed 3 more METS, and then 1 of the previously treated lesions was misbehaving. So given the fact that she had the other 3 that were new, it was thought that these were all, that the previously treated was recurrent, and she had SRS again. Everything looked really good. She then presented with some gait instability, and now the only lesion that's misbehaving is the one that had been previously treated. I got to move this around a little bit so I can see a little better. So of course our differential is it, is it a recurrent MET? Is it radiation necrosis? Sitting in on different meetings up at Monteris or at the different conferences, the one thing I found is that it's amazing how much different institutions do things. So I don't know what you guys would do, different people would do. If anybody wants to chime in and tell me what they would do with this lesion, I'd be certainly interested in hearing. If nobody says anything, I'll just throw out some things that I would think about myself. So sometimes we put this patient on steroids and watch them and see if the imaging got better. And if on steroids, the imaging got better, we'd think, okay, this must have been radiation necrosis. Other times we'd biopsy it. I think, vitamin E is something some people would do just empirically to see. But what we're thinking about here is it's been irradiated twice. She's on chemotherapy and immunotherapy. In my practice, we really want to know what this is. And so we came up with a plan to biopsy it and at the same time do the laser. In this case, this is kind of a round, spherical lesion. So I use the diffuse tip for this. I use the bigger one. I almost always use the 3.3 over the 2.2. Obviously, we're concerned about edema. Remember, when we use the laser, we induce edema. Okay, so we make, the beauty of the craniotomy is you're removing mass effect. With the laser, you're not removing mass effect. In fact, I believe we're creating mass effect. So I'm worried about edema. I'm worried about hydrocephalus. And again, I just have this thing here. So what do? So we do a stereotactic biopsy. If it's a recurrent lesion, your decision tree could be re-irradiate it for a 3rd time, resect it, or maybe use the laser. If you biopsy it and it's radiation necrosis, you could put them on steroids, you could put them on Avastin. The beauty here is that I think you can use the laser very effectively to treat radiation necrosis. So what if anybody wants to chime in at any time and tell me what they would have done with this patient, feel free, just interrupt me.
Question is steroids and biopsy if no response? Question mark. Advanced MRI? Question mark.
Yeah. So I think those are great points. So MR, whether you use a combination of MR spec or MR perfusion to try to figure it out, I think that's reasonable. I think this is a lesion that you probably could get a good signal for MR spec. In my practice, we're not huge believers in the result with MR spec. That's the bias that our team has. It's the bias our neuroradiologists have. So in our case, so I think that those are all reasonable options. What we did was we did a biopsy, and then we used the laser. And again, what's nice about it, you'll hear me say over and over again, it's minimally invasive. Why is that great in this case? Well, we don't really have to interrupt her chemotherapy. So, a lot of my craniotomy patients, their chemotherapy is going to be interrupted for about 2 weeks with an open craniotomy. We don't really withhold the chemotherapy at all with these patients. I mean, if they're scheduled to get the dose the next day, we probably don't give it, but we don't really mess with the schedule all that much, which I think is attractive with these patients. And again, it's going to treat both things in one surgery. So I'm doing this all, in this case, I'm doing this all in one procedure. I'm not doing the biopsy and coming back 2 weeks later with a final result. I'm going to treat it either way. And this is what it looks like on the top screen. On the top block there is 1 day after surgery. And then on the bottom screen was 6 weeks after surgery. See that on that axial flare there? You can see that edema that we've induced. It's a little bit worse than it was pre-op. I don't do anything special on this. I don't put them on mannitol. I just watch them clinically. I think that that's the right thing to do. And if there's a clinical problem, we deal with it. I do counsel these patients that they might, get into a problem where we have to put a ventricular drain in or something like that. But I counsel them that way for open crania as well. And then this is what it looked like 6 weeks later. This was a radiation necrosis. Go ahead. Was someone going to comment?
Yeah. Do you have a size criteria to treat it with a laser? If there's a radiation necrosis, large area, how big size is your limitations?
So I mean, there are a lot of papers out there where early on they were treating these really large thalamic GBMs and things like that, and they were getting into a lot of trouble with mass effect, and it got to the point where some people were actually, and some people still do, they plan on treating those large lesions, but then what they plan on doing is they're going to do the laser, and then they're going to go back to the operating room, and they're actually going to debulk some of the necrotic tissue that they've created. I haven't done that in a staged way where I planned for it. For me, it's really about, I think what people quote is like 15, cubic milliliters? That's not right. Cubic centimeters? What's the number?
It's 15, probably around like 3 cm, right? For 3 cm.
Yeah. About 3 centimeters diameter, Dr. Sun, is what we hear. I think a lot of people say is kind of the limit.
And I've treated lesions larger than that. When I have, it's been multiple trajectories. It's been irregular shaped. And there's usually been a way that I thought I was going to get away with it. Like it's a previous GBM resection where there's a large resection cavity. And now it's recurred along 2 borders of that cavity. And if you add up the volume, it's going to be more than that. But for a solitary lesion like this, I think 3 centimeters is sort of where I go. I can't get my brain around volume for some reason. It's just never worked that way for these lesions. So I'm really looking at the measurement. And I'm also looking at, can I really cover it? Am I really going to be able to cover it? It's beautiful that it's minimally invasive, but if you're going to do 3 trajectories for 6 hours and you could have taken it out in 2.5 hours in the operating room, I'm not sure. There's a win-loss there that needs to be considered. But it's a great question. This next slide, I have biopsy issues. So this is just something I want you to know about. So every time you do a biopsy, you cause a tissue artifact in your lesion. And that tissue artifact is going to show up on your your thermal data, okay? So, your pathologist is going to want lots of great cores of tissue, but there's kind of a balance. Like if you take out too much tissue, this artifact causes dropout. And so you don't get any thermal data there. And that can be very frustrating. So, you have to balance, you know, you need good tissue quality to know what you're treating, but you don't necessarily want to cause too much artifact. So there's just something to be aware of. The second thing, you know, when your biopsy needle's in there, there's a lot of anecdotal data, and when I say anecdotal data, I mean this is just what guys tell each other, okay? But I do think it's real in my own hands. You know, some people will, and I do this, if I do a biopsy, I've got the biopsy needle in the lesion. Before I pull the biopsy needle out, I will inject a little bit of thrombin. And the thought is that's causing some local vasoconstriction. And vasoconstriction, you know, blood vessels are going to be a heat sink, so that little bit of vasoconstriction might promote heating. I can't swear that it does it. I can say that I haven't seen a complication because of it. So giving that thrombin, I haven't seen that I've somehow induced an ischemic event or anything like that. And I do think that it actually helps, but I can't prove it. All right, so that's just a technical issue on biopsies. Let's keep moving forward. So this is another case. This is the same kind of story. All right, so this is somebody who had a renal cell cancer, had a cranie, had SRS, did well, had a recurrence, has new systemic disease. So we, did I screw up a slide there? Hold on. Okay, so this first one, this first column is 3 years post SRS. So we have this enhancing lesion, we have some edema. We're right back to that same question we just asked before. Is it a recurrence? Is it radiation necrosis? We did the same plan. So we did a biopsy and we used the laser. This is another lesion I treated with a diffuse tip. I just wanted a nice big round lesion. I always treat the blue line. So we talk about yellow line, blue line, and white line. I do think that some folks will say that it's okay with radiation necrosis to target the yellow line. I target everything in the blue line. And part of that is just because, you know, our biopsy there's sampling bias, right? So a lot of people will tell you every time you get radiation necrosis, you can't swear that there isn't some tumor in there and vice versa. So I just treat the blue line whenever I can safely treat the blue line. This is an interesting case. So, well, let's look at the picture. So you can see sort of what it looked like a day after. You see how much more edema there is the next day. But 3 years, I actually just saw her. She's actually like more than 3 years out now. She's had no recurrence. This is a patient where she had new systemic disease at the time. She didn't have to interrupt her new chemotherapy. We didn't have to consider Avastin for her. So this is a nice example of treating radiation necrosis. Now, one of the things I want to highlight here is this lesion is very close to the surface. And you know, you think about that GBM that was mesial. This lesion is very close to the surface. So on one hand, you say, well, the lesion's right up against the surface. Just go take it out. You know, just do a cranie. I like minimally invasive. You know, she's already had surgery before. She's already been radiated before. A 15 blade scalpel cut is going to be a much less risky incision than a redo craniotomy for wound healing. So it's got that value. But lesions on the surface have one little complexity, which is your anchor bolt that holds the laser, the probe driver. It's made of titanium, and it causes some artifact. So there's an issue there that you just want to be aware of. You know, the anchor bolt will cause artifact on the MRI scan. And so when you're screwing that anchor bolt in, you have to have good rigid fixation no matter what, okay? But, you know, and if you're dealing with an inch of, if you're up at the top and you've got a centimeter of good bone, you can crank that thing forever. Of course, down, temporal bone, which is thinner, you've got to get good purchase. But in this case, I had good bone here, but I screw it in enough that it's secure. It's got to be secure. But I don't screw it in so far that anchor is really pushing into the brain, because the farther that anchor is, the more surface artifact I'm going to get. Okay? And that surface artifact is going to make it impossible for me to see what I'm really heating. VP shunts, by the way, also cause artifact. And I learned this the hard way when I had a kid who I wanted to laser a lesion on the right. His shunt was on the left. I actually looked at a bunch of MRI scans ahead of time and basically proved to myself, yeah, there's not a lot of artifact where I want to target from this shunt valve. I said I'm good to go, and I got in the artifact, and on the Montera scans, there was horrible artifact. So shunts will also cause artifact, even if they're a distance away. Just something to know. Okay. What we did in that case was we very uncomfortably did timed burns, where we basically would laser for a bit, we'd stop and we'd get a scan, and then we would pull back, and we sort of saw what we saw after doing 5 minutes of lasering, and then we said, okay, empirically, I'm going to pull back and I'll do 4 minutes of lasering, and we'll get a scan, see what we see, and then it was a rough day, but now you know shunts will cause that artifact. It's something you need to consider.
With a stereotactic biopsy, do you use the same track for the LITT path?
I do. So the answer is yes. I use the same path. If I'm doing 2 trajectories where I'm going to use 1 trajectory to make a biopsy path, when I put the second bolt in, I will pass something, whether it's a biopsy needle or the I don't know what it's called, the probe, the metal stick. It looks like an ice pick. But basically I will make a track through the brain for the laser, so the laser doesn't have to do it de novo. I do that. I also do a scan after I place my anchor bolts, and I've done that. I actually do an intraoperative CT scan to see what my trajectories look like. And the reason I started to do that was just for once you're down. So remember, I have a diagnostic MRI scan. So once I'm downstairs and I'm going to see for the first time where my laser is, if I don't like where it is, I'm stuck because I'm already downstairs. So what I do now is I do my trajectory, I plan it, I go to the operating room, I place the bolt. If I'm going to do a biopsy, that's going to make my track. If I'm not going to do a biopsy, I pass the metal stylet, for lack of a better word, through to make a tract through the brain tissue, and then I'll get a scan, an intraoperative CT, and I'll see where my probe is going to be. And if all of a sudden I'm like, oh my gosh, I wanted to be dead center in the middle of the globe here, and I'm way off for some reason, which has only happened once, but if I'm off, because I'm in the operating room, I have the opportunity right then and there to say, you know what, I need to add a second trajectory. So I'll add that second trajectory while I'm there. My case is now going to be longer because I'm going to be doing 2 trajectories downstairs, but I know I'm going to have the capacity to cover the lesion. Because like I mentioned before, this whole surgery is based on getting the laser probe where you want it to be. The second question.
Yep, second question. For biopsies, have you compared injecting thrombin versus flow seal, Surgiflow, and the track in terms of subsequent ablation results?
I have not. I've never actually done that, injected flow. I know some people do, especially if there's bleeding during the biopsy, but I have not done that. But I do believe that 1 to 2 cc's of gently injected thrombin does help. I don't know what the artifact would look like if I injected flow. Ian, have you ever done that?
I have not. I've injected. I had to inject thrombin a number of times because of bleeding, but I don't know that it helps my ablation. I have a sense that because I only do it for bleeding, in general, those ablations don't go as well because there's blood there now.
Yeah, sure. All right, this third case, same story, different patient, 48-year-old with breast cancer. The top one is her pre-op scan. She had this left deep frontal lesion. She had SRS for that lesion. She did very well. 4 weeks after SRS is what the middle pictures look like. You can see the lesion has shrunk, the edema's gone away. Now, 4 months post SRS, she now has 2 lesions. So she has one that's a little more medial parietal, and the one that was previously treated with stereotactic radiosurgeries come back. So we're thinking that we've got a new MET, and we don't know what this other lesion is. What I decided to do was biopsy it again. It's the same story. Okay, I biopsied this lesion, and then I lasered it, thinking, hey, this is going to go just like the other ones did. And what ended up happening was she actually did very poorly. So it's the same story for why I did it. The logic sequence was the same, but she did poorly. She had aphasia and she had weakness before surgery. That aphasia and that weakness was worse after surgery, and it just wasn't getting better. We put her on high-dose steroids for a while, thinking we could ride it out. Every time we weaned the steroids, she'd get worse again. And this went on for a good 6-8 weeks before we finally pulled the trigger and put her on Avastin. And when we put her on Avastin, miraculously, everything got better. So when I look at this case and I say I wouldn't have done this again, I think the thing that makes this case different for me, and what I want to highlight here, for right or for wrong, is, I think that this patient's problem was really the edema. So the preoperative edema was where this patient's problem was, okay? And obviously we need to treat the lesion, but it's really what's making this patient worse is all that edema. And so when we use the laser, it's a great case for the laser. It's deep, it's the right size, but we're going to induce even more swelling. Now, it luckily didn't get to the point where, I'm thinking I need to go in there and debulk something, because she never really was in any kind of critical condition. She was never in a situation where it's like, oh my gosh, she's herniating or anything like that. She just wasn't getting better. And so I've had a couple patients where, they ended up getting 2 weeks steroid taper, and, 6, 7, 8 days in, they're calling with bad headaches, and we bumped their steroids up again, and we were able to ride it out that way. But this is a patient where if I had to do it over again, I would have more appreciated that it was the edema causing this patient's symptoms, and putting a name on it with a biopsy would have been right. But this is a patient I would have rather biopsied and then had them treat medically rather than use the laser. So I think it's just an interesting case. Questions about that one?
Yeah, I have a couple, I guess, comments or questions.
Sure.
How did you approach it? Like from this, did you take a posterior approach or come?
I took a more anterior approach.
More anterior approach. Okay.
Yeah. I didn't want to come across the manuscript.
And she started off with hemiparesis, right?
Yeah, she was weak, but she wasn't plegic. Afterwards, she was almost plegic.
Yeah, I mean, I think like when I see these patients, like if they are already hemiparetic, in my experience, these are the patients that if they have pre-op deficits after ablation, I typically make them worse with the ablation. If she started off like more or less intact, then you're more likely to get away with it. I also find that the subcortical lesions don't tolerate that edema as well as like I've actually gotten away more so with like biopsying lesions in the primary motor cortex more so than in the path of the cortical spinal tract.
Yeah.
White matter.
And another thing to add is, I didn't do it on this case, but if you have fiber tracking, whether you have it from an fMRI that you seeded or you use, one of the navigation softwares that fiber track. I do know a lot of guys will fuse the fiber tracking object when they go do the laser to sort of make sure that they're not, heating into the fiber tracks, because we are probably close to the corticospinal tracts there. I think we're a little anterior.
Yeah.
But again, she, the fact that she got better after we, after the Avastin, made me feel like we didn't cause a permanent structural injury there, but we just didn't accomplish the goal.
Yeah, I guess that's the other thing is also about like patient counseling. Like if you anticipate that they're going to get worse, but you also can anticipate that it's probably going to be temporary, they might be, at least they won't be surprised by it, I guess.
Right, absolutely.
But, the last thing I was going to say, I'm a big believer in biopsies. I almost always do a biopsy, but I do actually, the literature that's come across, particularly that's come out of the Lantern study, seems to suggest that the behavior after the ablation is pretty indicative of what the pathology is. Like if it stays away, then it was radiation necrosis. And if it comes back, then it's recurrent disease. And it doesn't really matter what the biopsy shows. Like if it comes back, that's got to be recurrent disease. That really is not radiation necrosis. And so if that's the case, then, and you're doing your biopsy and your ablation in the same setting, it seems like that the post-operative behavior is a better indicator of what it is more so than your actual biopsy.
Right. You just don't know, right? You just don't know until it misbehaves.
Right. Yeah, exactly. Yeah, but I mean,
I'm very biopsy driven, mostly because my oncologists are very biopsy driven.
Yeah, I mean, I always do biopsy, and I've been burned out because of bleeding a couple times and stuff. But then also, there is this tension where you do a biopsy and it shows radiation necrosis, but then it gets worse, and they're like, oh, but it's radiation necrosis, and like, no, it's just my biopsy. There's sampling error there. It's like,
Right.
Yeah,
exactly.
Yeah, I mean, I had a case like that recently where I did it was recurrent. It looked like recurrent enhancement after radiosurgery. We did an ablation, got a nice ablation, a gross total ablation, but then it recurred. And then because I was concerned about the sampling error issue, I took him back for an open craniotomy to ensure that I got enough tissue, and it was recurrent.
Yeah, I mean, that's the problem, and that's why I don't do the yellow line ablation on radiation necrosis. That's why I do try to accomplish a blue line treatment on all of them. So.
Yeah, I have a question. And for this anterior lesion, and this was treated with SRS first, and then showed some necrosis first recurrent. You did biopsy, you did laser, and then you manage with the dexamethasone, and then finally you have to use Avastin. And what is the other different approach? And since Avastin is so effective treating necrosis, if you know for sure it's a necrosis, are you trying to treat Avastin first, or you try to treat it with a laser ablation?
So that's a great question. So that I think is very institutionally sensitive. So I think that there are some institutions where Avastin is a curse word, and they don't want to give Avastin for anything until they absolutely have to. I think other institutions think steroids are the worst of all things. So what we do is I try to not use Avastin until I have to. I mean, there are certain things that are obviously contraindications to Avastin. So if you've got a lung cancer, a large mediastinal, a large medial lung cancer, that's a contraindication for Avastin. Patients have tons of other contraindications for Avastin. I think Avastin works beautifully, but if I think that I can treat the lesion effectively with a laser, such that we can withhold the Avastin, that's what I tend to like to do. But all those decisions in my group are made conjointly, with the rad onc and the neuro-oncologist together. So, sometimes they say there's in this patient, there's an additional benefit to giving Avastin. This is our excuse. So I'm like, okay, well then we'll do the biopsy and do Avastin. Does that make sense?
Yeah.
Yeah, it's really case by case.
Mm-hmm.
All right, let's move on to something else. What else do we have here? All right, this is me getting to show my failures. So, all right, so this is a 20-year-old who presented with seizures, and she has this lesion. So she's got this right, it's a non-dominant right mesial temporal lesion. I take her to the operating room, and I resect it, and lo and behold, and this is the area where if I'm going to leave something behind, this is where I'm sort of under the shelf of the cortex deep. I felt pretty good about all this, but you can see right here where I leave a little bit of residual tumor. So it's a grade 2. She did very well from the craniotomy. It's a grade 2 astrocytoma. It's MGMT negative. So we got this low-grade glioma, and if you go by the textbooks and you sort of say, how do we stratify these patients? Well, if they're under 40, they're low risk. If they're over 40, they're high risk. If you have a subtotal resection, they're high risk. If you have a gross total resection, they're low risk, and you're really talking about adjuvant therapy here based on the risk assessment. So, we're looking at this patient in tumor board and we're saying, well, it's not a gross total resection, so she needs radiation. And I'm just thinking, damn it, why didn't I just resect the whole thing? Maybe I should take her back. So I'm thinking, you know what, maybe I should take her back to the operating room. I should at least offer her surgery to go back and make this a gross total resection. And then it pops into my head that, boy, that would be a great case to laser. I have no data for this, okay? But this is the example of, like, when the light comes on in your brain that the laser is an equal part of your armamentarium. This is what I did. So she's got this lesion. I talked to her and I explained to her that, a gross total resection puts her in this low risk category and we can hold off on her radiation. And we could consider using the laser. Of course, I counseled her that, you know, I don't have data that a subtotal resection plus the laser is going to be the same. You know, we do our due diligence. But she wanted to do it. And so this is what we did. So again, this is pre-op. This is what it was 1 day post-op. You can see this residual here. This is the trajectory that I used, and this is the burn. This is what it looked like 1 day after surgery. I'm showing you all flares since it was a flare lesion. And this is what it looked like 8 weeks later. So, you know, it's minimally invasive. Theoretically, this is now a gross total resection. And the reason I present this is because this is the way I think about the laser. So I think of brain surgery for tumors as cytoreductive surgery. I think of the laser as cytoreductive surgery. It's just a different way to do cytoreductive surgery. And so if you think there's benefit to cytoreduction, this is where I think it comes into play. So I wanted to point this case out for that particular reason. I used the full fire. This is a very symmetric lesion, targeted right in the middle. We didn't need to do a biopsy here. We knew what it was, and she's done great so far. You know, I don't know. I'll have to wait and see if this ends up being someone who I can say, yeah, she responds just like somebody that would have been a upfront gross total resection. But I thought this was an interesting case. Questions about this case or talking points?
Hey, Dr. Sun, can you talk about positioning for these more posterior located lesions, like posterior temporal, parietal, occipital? Because it seems like it's really hard when you need a shoulder bump per se, especially in older people that have stiff necks. How do you get them to fit into that MRI?
So I don't have problem getting them in the MRI, but you know, so I guess it depends on the, you gotta think about the system you're using. I'm gonna jump to my last slide real quick to see if I can find that workflow. Is my workflow slide on there? There it is. So this is the equipment that I have. I use BrainLab for targeting. I have an intraoperative CT scanner. I use ROSA to place my bolts. If I didn't have ROSA, I would end up using the Vario guide to place the bolt, I think is what I'd probably be doing. I don't have an intraoperative MRI. So when I do my planning, obviously you get a thin cut MRI scan. I will frequently get a CTA, and that honestly comes more from my epilepsy background. When we do stereo EEG, we use CTAs to try to make sure we're not going to you know, cause a vascular collision. So I will frequently get a CTA to plan my trajectories. And then in the OR, I use that Atama system. And I really like it. So that's the Monteris table, transport table that basically has got their own head holder on it. I don't have a picture of it on here. But instead of being like a Mayfield with 3-point fixation sort of at, you know, the north and south poles, it's sort of a horseshoe shape, and you can put pins in a lot of different areas, and that it gives a lot of flexibility. So I've done cases prone in the MRI scanner with this system. I've done them on their side. I used to do a lot of surface registration for my procedures with ROSA. I don't know how many people have ROSA or are familiar with it, but it's a robotic system. And of course, anytime you start turning the head too far one way or the other, you're going to have problems with your surface registration. I've moved exclusively to using bone markers. So I tell my patients now they're going to get 6 incisions. They're going to get 5 tiny stab incisions for skull fiducials that I'm going to register the ROSA on, and then they're going to get a slightly larger than tiny incision for the laser. And using the Atama system, I have stopped having problems with positioning because I'll just turn them prone. We basically put chest rolls on the Atama board, and it's no different than it would be if it was on the OR table. And then what we do is we pick up the Atama board and we move them right onto the MRI table. So we bring we call them and we say we're ready. The MRI table comes upstairs. We move from the OR table onto the MRI table on that board, and then we head downstairs. So that has made it a lot easier for me. You know, the first time I did a hippocampectomy for epilepsy, I had the guy's head turned way over like this. I don't know if you can see me. And, I felt like I was drilling from underneath him. And since that time, I've really moved those patients. I just turn prone now, and I can do it that way. Does that answer the question? All right, so this is a case that we just did. So this is a 34-year-old with an insular glioma. He showed up in my office like 5 years ago or something like that. And at the time, he was having significant heroin abuse problems and things like that. He had what looked like a low-grade insular lesion. And I said, look, we got to get you cleaned up some before we do this. And of course, that was a mistake because he disappeared. And then he showed up at another hospital, and he ended up getting a craniotomy by somebody else where they removed the temporal component and they left the insular component. It was a grade 2. It regrew. He had a repeat surgery, and it was a grade 3. He got radiation and Timidar. They never really treated the insular component. And then on surveillance imaging, all of a sudden he has this new enhancement. So on this top block here, you can kind of see right here this enhancement. And this enhancement was new. And you can see it here. And then over here, you can see this flare signal change and this flare signal change, which also, when I compared it to his older studies, it had also been getting worse. So this T2 change is getting bigger, and it's got this new enhancement. And I don't know, what your experience is with insular gliomas. I hate insular gliomas. Every time, it's not every time, but I feel like a lot of the times I get these small perforator strokes and things like that. I promise it's not every time, but it feels that way based on the last bad one, right? So we all know that these are complicated cases, and for a long time I had actually been thinking, I wonder if on an insular glioma I could resect the safe stuff, the frontal stuff, the temporal stuff, and then come back and laser the opercular insular stuff. And I just never had the guts to do it because I was like, I can't really stop in the middle of the operation because I think I'm going to do a staged laser procedure later. So I never did it. And then this guy shows up having essentially had that done for me. So I talked to him and I explained to him his options. I told him we have to have tissue. It could be a recurrent grade 3. It might be a grade 4. It could be radiation change. And given the location in the insula, I told him that we had 2 options, repeat craniotomy, or we could do a 2 trajectory procedure. And one of the selling points for me in his case, not selling points, but one of the points for me was he had this substance abuse history. And I'm thinking to myself, and he's clean right now. And so I'm thinking, if I can do this procedure with a couple small incisions and not reopen what is now a 4-time redo craniotomy, who knows, maybe I'm going to keep him on less narcotics. A lot of my patients with this procedure don't go home on any narcotics at all, or if they do go home, they don't use them. So it seemed like an attractive option. On the bottom picture, I hope you can see the trajectories. I don't know if you can, they're hard to see, but you can see that there's 2 trajectories. They're sort of oblique frontal trajectories to the anterior and posterior insula. And we basically took him to the operating room, did the biopsy and did the procedure. And so this top one is the pre-op T1. Here's that enhancement that I didn't like. Here's the pre-op T2. And this is 1 day after the procedure. We just did this a couple weeks ago. And here's the post-op day 1 laser. You can see, there's these 2 different lasers that sort of coalesce, these 2 different areas that coalesce. But we actually got 100% blue line coverage of the T2 signal change. And, honestly, I was terrified. Is he going to get a perforator stroke from this? And he did beautifully. He went home the next day. So, if you look in the epilepsy data, I think that there's definitely cases of insular epilepsies that are now being treated with a laser. I think that's a beautiful place to do it. And now I sort of feel like you could consider this as well. So this was an interesting case for me. I'd wanted to do this for a while and I hadn't had the opportunity. Comments on this one?
That's a great case. It's a really, I've started to come around to that too, and that's just, I think that's, I really, I'm starting to really believe in treating, especially for the posterior superior insular tumors.
Yep. Yeah. So this went really well. I'm really pleased with it. I'm definitely going to look at it more. I don't think I'm going to. I don't know if I'm going to do my open cranie and stop on the insular component, but I think what I'm going to do is say to myself, it's okay to be a little more conservative because maybe I can then come back and like that other case where I can convert my subtotal resection into a gross total cytoreductive procedure. So I'm going to think about that a little more.
So I haven't really tried this hybrid approach where, you know, you do surgery and ablation. Either it's been all surgery or all ablation.
Right.
But I do feel like one of my partners just he had a patient who came in today with a large left insular mass, which is really, it's too big for an ablation, at least in one go. Yeah. Frankly, even with stage ablations, it would take a long time and many catheters to get a complete ablation. So what I thought might be a good idea for that case would be to do the ablation first of the posterior superior part, and then, you know, and then take out the rest of it. Because, you know, as much as I like laser ablation, I still feel like, you know, it's not a sure thing.
Right.
And also, like, when in these cases, like I recently had a case where I took out a large insular tumor, but there's some stuff left behind. But the stuff that's left behind is not really amenable to, you know, 1 or 2 laser targets. It would be like 5 targets.
Right. Yeah. So I think you said something really important there. You said, you know, with laser ablation, it's not a sure thing, and it's not. Like when you go in there and you get into the MRI scanner and you put your foot on the pedal, as much as you've predicted where the heating pattern is going to be, you don't know until you see it, you know, and it feels a little bit it feels a little more out of control than in the operating room. So in the operating room, I might say, okay, I know I can't take this out because it's going into the basal ganglia or it's going into the motor strip or whatever the case may be, and I know I can't take that out, but I certainly have an expectation of what I know I can take out. And with the laser, you plan your trajectories based on thinking in an ideal circumstance, I'm going to be able to cover all of this. But you really don't know until you get in there. And sometimes there's artifact that's driving you crazy, or sometimes there's a blood vessel that's acting like a heat sink, or there's some bleeding, you know, that's acting like a heat sink. You just don't know. So I think that's an interesting perspective on it as well. There's something else I was going to say, and now I forgot what it was. Any other questions or comments on this case?
Dr. Sun, you talked about doing an intraoperative CT because you only have diagnostic MRI. With the bulk, and the table and everything, do you get a lot of artifact with that?
No, so we're using I'm on the OR table that's designed for my Aero CT. So that's got a lot of carbon fiber or whatever the heck it is, but it doesn't cause a lot of artifact. The bolt's going to cause artifact. And basically what I'm doing, all I'm really doing is I'm windowing, I get the CT and I window it to reduce the metal artifact as much as possible. And I'm really just saying, is the anchor bolt lining up with the trajectory that I wanted? And if it is, I'm good. Or if I did the scan with the metal stylet, you know, in the brain, which I will often do, then it's sort of going right down to the lesion. And then just on my software, I just sort of flip back and forth. Is it in the right place? So there is artifact, but you're not really looking at the soft tissue. You really are basically taking that scan and then fusing it to your pre-op trajectory scan and saying, yep, I'm good or I'm not good.
Okay.
One other thing, I know the other thing I wanted to mention, talking about low grades and staged, is, you know, some of these lesions that are, you know, low grade lesions, you could consider, you know, like a large, I don't know, a decently sized low grade tumor flare signal lesion. I know that there are folks out there now that will do staged laser ablations for it. So they'll laser it and they'll get 30% of the lesion and then they'll stop. And then they'll come back, you know, 4 weeks later or 6 weeks later or whatever, do a new scan and then target another stage of the ablation. I know some folks are starting to do that on cases. I haven't been doing that. I haven't done that yet, where they're saying to themselves, I've got a low-grade lesion. I'm not expecting it to blow up in my face in the next 4 to 6 weeks. So I'll do actually a staged laser separated over time. I know Dr. Luthart presented a case like that from WashU once, and I know a couple other folks around that have done that a couple of times. I haven't done it yet. I've been looking for the opportunity to do it, but if I was going to do it, I would certainly be doing it where not over multiple months, but over the course of multiple weeks. Okay, so this is an interesting one. So this is something that I was thinking about a long time ago when the first time I went to one of the Monteris meetings, and there were some neuro-oncologists there and a bunch of neurosurgeons there. And the question about multifocal lesions came up. You know, we certainly know the data on what we're supposed to do to resect the high-grade glioma. We're supposed to get as much of the enhancing tissue as we can, and we know that the more of it we get, the better the patient's going to do. This is a 58-year-old. He presented with altered mental status. And what you can see on these images, these top images here, is this coronal, for example, he's got a large right frontal lesion, and he's got this little satellite lesion down below. This is a different cut here that just shows the satellite lesion on the axial and then this large lesion here. So with this guy, I just decided I'm going to do a craniotomy, and I wasn't going to go chasing after this multifocality. So this was the post-op day 1 resection. I was pleased with the resection. It came back as a GBM, and he's got this residual. Now, his performance status is great. So he did great from surgery. All of his altered mental status is improved 2 weeks after surgery. We have our path. He's got a GBM. He's got this area of enhancement. And this, again, it's a cytoreductive procedure. So I said, okay, no one's ever really, we don't really know, you know, what this does. So this one for me is a very experimental type case. I'm not saying that I have data for this or that I've read papers about this, but this is something that I've been thinking about. So we lasered the enhancement here. And this is what it looked like one day after the procedure. So at this point, I'm treating him like, I'm in my mind, he's a gross total resection. And he goes on to get his adjuvant therapy. And then boom, lo and behold, about 7 months later, he's got this new area of enhancement, okay? It's distant from the other sites. This white arrow actually shows the area that I previously lasered. Okay, so this is the satellite that I previously lasered, and it's stable 7 months later. His resection cavity is stable 7 months later, but now he's got this new spot. So what do? He's doing great. We went ahead and said, well, we're kind of playing whack-a-mole now. So here's another area that's popped up. Let's biopsy this. This could be radiation necrosis. This could be in the field. I feel like we're far enough out that it's not pseudo-progression. So we go, we biopsy it, and we laser this. And I'm going to wait and see what happens. Okay, so, you know, why use the laser on this? Honestly, my answer is, you know, joking aside, is why not? Why not try? If he's got an excellent performance status, he's doing well, why not? I don't know if it's going to be helpful or not. This is where we need the registry to answer the question. You know, we'll need to look at these patients. I don't know how many of these patients are going to end up in the registry. But, you know, we're just going to need to see what happens with these patients over time to see if we feel like we're actually making a difference or not.
I think it's a good use for LITT. I mean, recurrent GBM is just a sucky disease in general.
Yeah.
And so, you know, you're bang for the buck. You're not expecting like a huge benefit from this, but a redo craniotomy for something that has not very much benefit is also kind of crappy to do.
Right. Yeah.
So, you know, I think it's a good big mixture of, you know, get them a little bit of benefit for something that's not, you know, that's less risky than an open procedure and less recovery time.
Right. You know, this patient also goes home the next day, you know.
Yeah.
So that's all the cases I built. I didn't think we'd actually get through them all. I must have gone fast. So these are the cases that I have. I'm happy to talk about anything anybody wants to talk about.
Well, I think we're actually probably a little bit past the time we scheduled, but it was a great discussion, so I'm glad we had it. And I'll first thank you, Dr. Sun. I think you put together some really good cases to sort of lay out some good discussion. Hopefully everybody that joined us found it beneficial. And I wanted to make sure I just said thanks for joining us to everybody. And again, thank you, Dr. Sun, for taking the time to pull this together and share a little experience.
No, thank you. I appreciate everybody coming on.